seconds. All right. So welcome to Children's National. I recognize quite a few of you, but there are more of you that I don't know than I do. So, well, welcome to Children's National and working for a level 1 trauma hospital. For those of you who know me, you know me. And for those of you who don't, I'll give you a little bit of a brief background. So I'm Cindy. I started out in my career in EMS over 20 years ago, and that makes me a little bit nauseated. I was an EMT basic, and then I became a paramedic. After that, I started at Children's in 2008 as a paramedic on the transport team. And then I was like, wow, nursing's awesome. I should do that. And so I became a nurse, and I was a new grad in our PICU as a PICU bedside nurse and worked there for a while. And for fun, I went back to school and got my master's because I thought, why not? I mean, it's always good to have it in your back pocket. And then I met our trauma team here. And I met our trauma team at like a much deeper level. And now I work for them, and I do injury prevention, education, and outreach. And then I recently decided that I needed to go back to school again. And I'm now in the acute care, primary care, pediatric nurse practitioner, DNP program at Hopkins. So I am at the hospital most days, definitely Monday through Friday. And you see me around, say hi. And I'm just excited to be here and tell you a little bit about what it's like to work in a hospital that has a level 1 pediatric trauma center. All right, so we are a level 1 pediatric trauma center. We were established as a trauma hospital in 1980. You know what else happened in 1980? I was born, which is really concerning. So I kind of feel like it was like a match made in heaven. Being a level 1 trauma hospital is a systematic approach to the injured child. We are part of the Maryland shock trauma system. We do part of the curriculum for the pediatric emergency and trauma care for the pre-hospital provider. We're involved in emergency medical services for children. And obviously we have a well-established approach to childhood and injury prevention. You know, with trauma, it's the only specialty in the hospital that requires to have a designated person to put the department out of business. That's my job. Part of my job is to prevent kids from being injured when our trauma department is taking care of kids that are injured. I always think that that's interesting that they literally have somebody that's supposed to put them out of business. I don't think I'm doing the best job because we're definitely not out of business, but we're doing everything that we can. So, you know, regulatory agencies, we all love them, right? So if you were ever interested in who designates a trauma center versus who verifies a trauma center, so we are designated with the state of Maryland, but we are verified by the state of Maryland and the American College of Surgeons. So what does that mean? It means that every so often, so every couple of years, these two entities, the state of Maryland and the American College of Surgeons, go through our program with a very fine-tooth comb to make sure that we hit all of these criteria. So everything's based off of like this massive, this book, it's called the Orange Book, and it's basically just a list of everything that you have to have, and through the Maryland Institute of Emergency Medical Services. So we have to have institutional commitment from the CEO and the board of the medical staff. We have to have a budget to support our staff. We have to have credentialed general surgeons, ED physicians, subspecialist neurosurgery, and orthopedics. And we have to have 24-hour support in pretty much every single specialty that deals with the trauma patient. So radiology, the OR, PACU, PICU, rehab, anesthesia. And we also have to have social workers that are equipped to take care of our trauma patients, and nurses, which is why we are all here today. Nursing has to have the education and the support to take care of our trauma and burn patients. We have to have trauma resuscitation bays. We have to have specialized equipment in the OR to we have to have special equipment in the OR and special equipment in the trauma bay. Our trauma team has to be on call 24/7. We always have to have a senior level surgeon in-house. We also have a trauma registry. So every single trauma patient we collect data on, and on all of the trauma admissions, and it goes into this massive registry that is nationally done. So they collect all of the data for all of the trauma patients in the nation. We also have to monitor our deaths, our severity of injury, complications, outcome. We also are required to do pre-hospital interface and feedback. So we work with our EMS providers and give them follow-up on what went well, what went wrong, how can we help you do better, and also tell people like you did a great job. On one second. We have to provide education for surgeons. We have to provide education for physicians. We have to give you guys education, which is why we are here today. We have to also count how many hours each person gets. Again, another reason why we are here today. We have to have a certain number of research projects that are, approved by IRB. We have to have a minimum of 12 peer-reviewed trauma-related publications per year and presentations outside per year. So we have to do research. That's part of being a level 1 trauma hospital. And then one of the most important things about being a level 1 trauma hospital for pediatrics is that we have to have a PI process, so performance improvement process, to track patient care and outcomes. So we track every kid to make sure that we are doing the same thing for every kid every time. That's a lot. It's a lot to be a level 1 trauma hospital. So that brings up, I think I talked a lot about the education component and how important it is. So this is like one of the times to definitely pay attention. All right, if you see your units on here, so these are surgical care, neuroscience, PICU, acute care float pool, critical care float pool, crisis, the emergency department, the PACU, and the OR. This is how many hours of burn and trauma-related education you need per year. So this is every year. You have to show proof of these by June 30th of every year. So it's a fiscal year. It's not a rolling year. It is a 12-month fiscal year. So the year starts July 1st and ends June 30th. So everybody today, if you do everything today, you have all of your trauma hours, but you still might need burn, because I think we have 1.75 burn today. But again, all of that is listed on your CNEs, so you'll be able to add them easily. So this is the total number of cumulative hours you need, and these are the hours in each section. And this is every single year. Our trauma medical director is Dr. Bird. If you have not seen him, this is what he looks like. This is him saying hi to Flash Max. Flash Max is a injury prevention fire superhero. This is our surgical team. So I really appreciated when Dr. Maceros went through and talked about kind of like the stratification of like the different, oh my goodness, you can see my hand like go in and out. Sorry, I got distracted with that. Dr. Maceros was talking about like the PAs and the residents and the attendings. So for general surgery, we are working in an academic hospital. So if you haven't worked in an academic hospital before, this could be a little different. If you have, it's not going to be any different at all. So when we talk about an academic hospital, we have attendings, we have fellows, and we have residents in surgery. So our attendings, they're the ones that are, the top dog. They're the ones that are the final say. They are the ones that have been here and are going to continue to be here. We have surgical fellows. We normally have 2, sometimes 3 at a time, and they rotate and they stay here for 2 years, 2 years at a time. And then we have our surgery residents, and they rotate here every 2 months. That's the average. So they could only be here for 1 month, 2 months, or 3 months. The average is 2 months. So when you're talking about, the chain of command and what to do, if you are not getting where you need to with the surgery resident, You can escalate to your fellows and residents on whatever floor you're at, or you can start to escalate up to the surgery fellows. And then the next level after that is our surgery attendings. But make sure that you keep your team on your floor in the loop as well. And then we have our trauma and burn nurse practitioners. These guys are going to be your best friends. All of these were nurses first. Most of these were nurses in a pediatric ICU first. This is a number you want to write down. If you don't have this number memorized, this is something you want to write down. So these are nurse practitioners that will be able to answer questions for you and help you troubleshoot whenever they are here. And they are here like daytime hours, so probably till about like 5 or 6. So like 7 to 5. And so it's 202-476-8212. This is how to get the inpatient nurse practitioner. This is an important number. And like these guys, these are your resources. These are probably the first people. So we were talking about like escalating and like how to like go up the chain. These are the people that you want on your side. These are the people that will come to your bedside and help you out if you have a question. Other resources. So you guys met me and I am here. Feel free to contact me at any point. Oh, I guess I should give you my office number. So it's 202-476-7754. That number will ring to my office phone and also to my cell phone because I have it forwarded. So if you need anything and you have a question about a patient or you like, call me. I will come. I will do whatever I can to help. Our trauma program manager, that's Jen Fritzine. If you haven't met her, this is what she looks like. I love this picture of her because it shows like how dedicated she really is to our program. And she's literally like laying on the floor, taking a picture of a baby in a papoose collar to make sure that we have pictures of like how things should be properly done. And then we have our PI coordinator. So I was talking about like the like all the things that we have to be a level 1 trauma center. And that is part like, that PI process. Well, the person who does all of that is Liz Weibel. And she's also an incredible resource. She started out here as a nurse in the emergency department. And then she became a nurse practitioner and she worked with trauma and burn for a long time as a nurse practitioner. And now she is our PI coordinator. So these are like three other people that you have that will have your back. So the nurse practitioner number 202-476-8212. That's a Monday through Friday thing. They're gonna start working on Saturdays, but everything got like halted because of COVID. So I'm not quite sure when that's gonna start again, but eventually they will be here on the weekends as well. And then just in case you missed it and I don't have it on my slide, if you ever have a question about education or something at the bedside or a patient or anything at all, my number is 202-476-7754. So feel free. Like, I am not a desk person. I'd much rather be like running about in the hospital. So I just want to make sure that you have the resources that you need. So thinking about like how our patients get to the hospital. So they come to our hospital from a variety of different ways. And we have our group, it's ECIC, and I wish I could remember, Emergency Communication Information Center. Got it. So that's what ECIC stands for. And I kind of think of them like air traffic control. So they are the ones navigating all of the children from the area coming into our hospital from all these different directions. So they monitor all communication from EMS ground. So that's, when somebody calls 911 and then the ambulance will call our hospital and say, hey, we're coming in with, a 7-year-old that got hit by a car. If it is a flight crew, same thing. Sorry about that. They are the ones that put out like some of the pages with all of the, like, I'm sure that you've been in this hospital for like a minute now. So I'm sure you've heard trauma stat attending, trauma transfer, med alert, PICU. They're the ones that are putting out those pages. They connect providers from outside hospitals and our EMS providers to our medical control physicians. So they're the ones, they're literally ECIC is the glue. They live on the top floor where the helipad is. So you can't get to it unless you have a special key for the elevator or if your badge is coded for that. But they are in an office at the very top at the helipad. And that's where they're doing all of these things. So they're taking calls from EMS, they're taking calls from other hospitals. They're also taking calls from physicians in doctor's offices that have questions that need to talk to other physicians or have questions about possibly transferring a kid to children. So ECIC is, they are really the hub and air traffic control for all children coming into the hospital. And it's not just for trauma patients, it's for patients for all specialties, for everything. So as you can imagine, they are pretty busy. And then I feel like I have to talk about our trauma team because that's where I started. And our trauma team they're awesome. I will say it's probably it is one of the best jobs in the hospital. And I started with them as a paramedic. And so we have a specialized transport team for pediatrics and for neonates that will go to other facilities and pick up children and bring them back. And they start children's care at the door as soon as they walk in. So it's like that child has already been admitted to children's because our team is an extension of that. And they're giving that excellent care as soon as they get to whatever referring facility it is, all the way back and back to children's. They use pediatric nurses, NICU nurses, and paramedics, and respiratory therapists if the call needs it. And sometimes they will take a physician, but that does not happen that often. I feel like it may happen a little bit more than it did when I was on the team, but it is great. And if you have any more questions about transport, feel free to let me know and I can get you in contact with a couple of people that work there now. But it's pretty awesome. And we have ground crews and flight crews and people who do both, who only do ground. And if you do flight, you've done ground and flight. Just to give you a little bit of a perspective of where we are and where the next closest level 1 trauma hospital is. So we're Children's National Hospital, not Medical Center anymore, but there's only 2. So there's Hopkins and then there's us. And we're the 2 closest. I think that the next closest PICU, big PICU, would be Inova. So we are that's the closest level 1 trauma center for children is at Hopkins. I talked a little bit about EMSC, so this really isn't all that important to you, but I think it's just good institutional knowledge. So EMSC is the Emergency Medical Services for Children. This is federally funded, and it assists us with being able to improve and support programs that help the medical and trauma care in children. One of the things that you may hear about in the future is pediatric readiness. So, adult hospitals, they don't really take care of kids that often. And if they do, they're let me get them out and get them to children's because we don't really know what to do with little people. There's being a lot of work done for pediatric readiness to make sure that even if you're an adult hospital, you have the right equipment to take care of children if you need to. So that is something that you may hear about in the future. And so now you heard a little bit about it now. Safe Kids, this was established also by Dr. Eichelberger in the 80s. This is basically it's an injury prevention program. And he started it here, and it has now turned into a worldwide program. So it's not just DC, it's not just Maryland, it's not just Virginia. There are Safe Kids programs in every state in the United States, and there are programs worldwide. Some of the things that they do is, they do stuff with car seat safety, pedestrian safety, home safety, and they do a National Safe Kids Week. If you even Google Safe Kids, you can get a ton of information about how to keep children safe. And I think it's pretty cool that it started here at Children's. a couple different things that we do in our department for the community. So before the pandemic started, and we were still doing in-person classes, we were doing Stop the Bleed classes all over DC, Maryland, and Virginia. We did a lot of training at like different colleges. We helped out the Smithsonian and trained their people before large events. And right now we aren't doing it. We still have not been cleared to do in-person classes like outside in the community and bring in community people into our hospital, but hopefully that will like change at some point. And we are in charge of the so we teach the period of purple crying and protecting children to every single daycare provider in the District of Columbia. So the Office of the Superintendent of Education has mandated this training that we provide to every single daycare provider. And I think that that speaks a lot to what Dr. Maceras just talked about, the incidence of abusive head trauma and shaken baby syndrome. That's what we're trying to reduce those numbers. We're trying to reduce those numbers, and we got, we got everybody on board to make this a mandatory education for all of our daycare providers. And I think that that's something pretty impressive and that I care very deeply about. Just briefly, I gotta go fast. I talk too much. You guys need a break before the next lecture. So when you hear trauma stat attending, or trauma transfer, this is just like a little list of like all of the reasons why they may call those. So if you hear trauma stat, you can think run of the mill trauma. If you hear trauma stat attending, that means it's bad. So if you are working as a nurse in the PICU and you hear trauma stat attending and you have the open bed, get ready, because most of the trauma stat attending kids end up in the PICU. This is what our code room looks like. One thing to, so we have 2 code rooms. They are complete mirror images of each other. So there's one on one side and there is one on the other side. And again, they're complete mirror images. So right here, if you look at the room, you can see the black line and then you can see the circle. Anybody standing in the circle is actually providing like hands-on care to the patient. And then anybody standing behind the black line, that's like the management line. So they're the ones kind of running the show and like not really barking out orders, but keeping the room under control. This is the list of like the different people. So I have it labeled here. So if you think about like who comes to a trauma, so behind that black line, for a trauma stat attending, we have a PICU fellow, surgical coordinator, surgical attending, and an ED physician. So they are behind the black line. Radiology kind of like hovers in between because they're ready to jump in whenever needed. And you think about like who's around the bed. So we have respiratory and therapy and anesthesia at the top. We have a surgery resident or one of our trauma and burn nurse practitioners on the right side, and a role that we call nurse right, which is often a tech. So and then we have nurse left, which is pretty much going to be the bedside nurse. There's a med RN or a pharmacist near the Pyxis, and if you look at this like down this hall like wall a little bit more, there's a long table with a bunch of stuff on it. And then we have the charge nurse, who's also pretty much like writing down everything that's going on and also helping everybody behind the black line manage the room. This is kind of what it looks like when there is a trauma. So this was a simulation, so don't worry, I'm not putting pictures of any children up here. This is a simulation, so you can see that the room gets packed pretty quick. Just as a reminder, trauma and burn hours are due every year. This is how many that you need. And right now, since you're taking this class, pretty much all of you are going to be done for the next year, so you don't really have to worry about it. But don't forget, come July 1, it all starts over again. And so if you need a break, everybody feel free to take a break. I'm going to stay on, and our next speaker is forensics and sexual assault. I will say for the next lecture, this is not one that we will be recording. One second.